Arterial venous fistulas are not uncommon, typically resulting from needle punctures to both the artery and the vein, or when there is right and left catheterization. Bleeding from the arterial puncture may track into the adjacent venous structures, forming an arterial venous fistula. These patients are also at higher risk if there have been multiple femoral punctures, a low femoral puncture, or a high SFA stick. AV fistula tend to be small and often resolve spontaneously. Some of these will present with a continuous murmur if you put the stethoscope over the groin, or an audible bruit. If you put your hand over the groin, you may feel a palpable thrill. When they're large enough, they can result in significant arterial insufficiency or swelling of the limb. However, in my experience, we don't see this very often. Here's an example of a patient who had a brachial artery stick. Here we see the brachial artery and the adjacent vein, and you can see the direct communication between the artery and the vein. One of the things that you don't see from this image is the color flow bruit that we often see in patients with fistulas. But keep in mind, I'll point you here to the fact that the PRF is set quite high at 153. And the reason for that was because we wanted to identify the communication site. As you can see now from this image in the same patient, the PRF has been dropped to 67, and you can now see the color flow bruit that is often seen in patients with arterial venous fistulas. In addition, Doppler evaluation of the adjacent artery reveals this continuous forward flow throughout the cardiac cycle. We know that in normal patients in the periphery, we should see a triphasic waveform, and this finding confirms the presence of the arterial venous fistula. Occasionally, you'll see patients who present with anastomotic pseudoaneurysms. Here's a patient who had catheterization with access through the groin, who had previously had a distal bypass graft. The patient presented to the vascular lab with groin pain and swelling, and this is the image that we acquired at the level of the proximal anastomosis, where you can see this large outpouching here. In fact, the pseudoaneurysm really enveloped most of the proximal anastomosis. This patient went on to have surgical repair of that lesion. Patients can sometimes present with infected hematomas or pseudoaneurysms. The typical presentation is pain and swelling at the puncture site with erythema, fever, and chills. This is a patient who had an infected hematoma in the groin. You can see here this pretty gnarly looking groin. This is the corresponding duplex image in that patient. The patient, in fact, had to go on to the operating room to have that hematoma evacuated. And this is all the blood and clot that was evacuated from that groin. False aneurysms are not uncommon in patients with dialysis access. This is a patient who in fact had a percutaneous transluminal angioplasty of a subclavian vein with access through the dialysis access itself. The patient presented with pain and swelling at the puncture site. This is the duplex image, 2D without color, and you really can't appreciate it, but what you're seeing here is the dialysis access itself with this large surrounding fluid-filled mass. When you turn the color on, you can see that some thrombus has formed within the sac itself. Again, this is the dialysis axis, and you can see that there's color flow still. The important thing here is to realize that you can get issues not just remote from the access site, but also at the access site itself. This pulsatile mass over the access site really was the clue in this patient. Relatively straightforward study. Patients can present with retroperitoneal hematomas. Typically occurs when there's puncture above the level of the inguinal ligament, and adequate pressure cannot be applied to the puncture site. In this case, you'll put the transducer down in the groin. These patients are often referred because the hematocrit is dropping or because there's been a drop in pressure. You put the transducer down in the groin, and the groin appears to be normal. Keep in mind with these high puncture sites that the issue may not be at the puncture site itself. It could be higher. The bleed could be anywhere, and you'll have to look up higher. Typically, the diagnosis for retroperitoneal hematoma should be a CT scan, but occasionally you'll get lucky. In this case, there's a patient with an iliac artery puncture with a contained bleed at that level. And this patient actually went on to thrombose with a little bit of duplex guided manual compression. But again, the diagnosis in these patients, the preferred diagnostic method is a CT scan. Dissection can be an issue in these patients. Some of the predisposing factors include tortuosity and atherosclerosis. Introduction of the wire can cause subintimal disruption, and you can have a wire or a needle that extends into the subintimal space. In some cases, this is very obvious, although in these two images, really it's not. You can see here from the color flow image that it appears as if this is just a stenosis at the level of the puncture site. So I would caution you in these patients where the predisposing factors point toward the possibility of dissection to just turn the color off and evaluate the patient with just the 2D. In this case, you can see this linear structure that, although it's not an obvious dissection, should point you in that direction if the risk factors are appropriate. The key question here to ask would have been, did the interventionalist have trouble passing the wire? Here, really another case, same patient, where the dissection is much more obvious based on the 2D image. In this case, the patient went on to get a stent to placate that dissection and to restore flow in a patient who was ischemic. Thrombotic occlusion can sometimes occur, and this will happen in patients who are under anticoagulated prior to their interventional procedures. It can occur in patients who are receiving larger sheets or long manual compression times or other occlusive procedures. As the flow in these patients is compromised, this is an image of a patient who had a femoral popliteal prosthetic bypass graft, and you can see in this 2D image that the flow or the presentation is quite normal. This patient actually had a C-clamp placed for occlusion after his interventional procedure, became ischemic. After the procedure, we went on to examine this patient afterwards, and there was no Doppler or visual evidence of active blood flow demonstrated within the lumen of this prosthetic graft, probably because of the compression from the C-clamp. Atheroembolism can be an issue in these patients, often happening if a catheter, because of catheter or wire-induced trauma of a friable plaque, which leads to distal embolization, and then arterial ischemia. Patients may sometimes present with blue toe syndrome, as the small emboli pass on to the very small distal vessels. There's an increased incidence of this phenomenon in patients with atherosclerotic aortas or when curved catheters are used. And this is an image of a posterior tibial artery with a little bit of atheroemboli, which you can see here is compromising the lumen. Arterial perforation can occur in a subset of patients and can range from a very minor bleed to sometimes major hemorrhage. I have not really seen this very often in the vascular lab. However, if you have occasion to spend a lot of time within the interventional suite, you might in fact encounter this complication. You should be suspicious when the patient complains of acute, severe pain with passing of the wire, the catheter, or the balloon. But again, in most cases, it's the contrast arteriogram which will cinch the diagnosis, as contrast injection shows extravasation of blood outside of the artery. And again, this is rarely diagnosed by duplex ultrasound. Some patients will receive closure devices, and these are being increasingly used in order to shorten length of stay and minimize the need for manual compression. However, we've seen both short and long-term complications in these patients, including infection, thrombosis, and bleeding. These devices come in various different configurations and different occlusion techniques, from clips to sutures to collagen plugs. And they'll present differently sonographically. Here's a patient who actually has a collagen plug inserted at a puncture site, and you can see the plug here on the near wall and also a shadow that's resulting from that. Here's the color flow image in the same patient. You can see the intraluminal plug, really extravascular collagen. You can see also that there's a little bit of a slight flow disturbance here generated by the fact that the lumen has been compromised and has resulted in an increased velocity. Here in this case, in a different kind of a closure device, a suture type closure device, nothing really appreciated by the 2D image. The flow really has been maintained, no abnormalities, no significant flow disturbances, no increases in velocity. We have experienced complications in these patients. You can see here thrombus by the 2D image forming around the closure device, and then the color flow image really just confirming the suspicion of the 2D image. You can see that the lumen has been significantly narrowed in this patient. Let's talk a little bit about some of the venous complications that one might experience. Deep vein thrombosis is a complication that can occur in patients who have right heart catheterization. Occasionally we'll see this in patients after undergoing IVC filter placement or some of the other various venous interventions that require access into the venous or arterial system. I located this paper recently, and it's titled Thrombosis of Common Femoral Vein After Left Heart Catheterization, an Unusual Complication Resulting from Application of a Compression Device, a case report and a review of the literature. And in fact, this particular patient had a femstop used in lieu of manual compression, which resulted in significant partially obstructive deep vein thrombosis. You have to be careful not only to look at the arterial structures in the groin, but also take a quick peek at the venous structures as well. Currently, we're offering endovenous ablation procedures for the treatment of varicose veins. And one of the major complications associated with this procedure is the potential for thrombus formation after the procedure has been completed. In this case, you can see here thrombus peeking out into the very distal common femoral vein at the level of the saphenofemoral junction. And again, you should be clued in to the potential for these issues in these patients and look for them on your post-procedure studies. Thrombophlebitis can be an issue. In this patient, we see a thrombosis of the cephalic vein. In fact, this patient is status post-thrombolytic therapy of the subclavian vein through a PICC line and presented with arm swelling, fever, and chills and pain along the cephalic vein distribution. A duplex scan revealed occlusion and dilation of the cephalic vein at the level of the puncture site as well as throughout the level of the upper arm. So in conclusion, with the increase in endovascular procedures, the number of complications that we see in the vascular lab is also increasing. I believe that the vascular lab can play a significant and major role in terms of diagnosis of these lesions as well as in follow-up and treatment. I believe that familiarity with the risk factors and the potential complications is key to the diagnosis, and always a conversation with the referring physician will allow you to better care for your patients. I'd like to thank you very much for your time and attention, and I hope this has been helpful.